Good afternoon. My name is Rick Dart, and I'm the Executive Director of the RADAR system. And I have a lot of data to show, so without more pleasantries, well, first, thank you for inviting me, because I had fun putting this talk together. It's the first time I've kind of put all this evidence together. But let's get into it. So last year at ISPE, actually, an FDA presentation talked about how they were going to use the Hill criteria for causation to evaluate opioids, and so that's the strategy I'm going to use here. And I've also got some questions, of course, that were asked by the Academy and that have come up in FDA AdComs. Well, the first Hill criteria really is plausibility, and of course we like to have some reasonable understanding and mechanism to believe that we think something works. That makes sense. Prescription drug abuse in general is like other drug abuse, except there really is an additional route of abuse, I would say, and that is that it isn't just ingestion or oral. You can ingest an intact tablet, or you can ingest a chewed or crushed tablet. And so that chewing and crushing is important because in recent years it's become much more apparent that this concept of manipulating and a transition that occurs when a person goes from simply swallowing to manipulating their drug is a crucial one. One example is a recent paper by Susan Vosberg that shows that perceptions of heroin abuse change once you start crushing. It may be not the crushing that causes it, but the person is changing, and that allows their behavior. And of course, there's the obvious issue that the risk of acute and chronic complications like infections goes way up with IV especially, but also with intranasal abuse. So what's the theory behind here? So the idea is I'm going to look at the person in pain. I'm going to focus on that, although I think most of this actually does apply to the recreational abuser. And the question is, how does that person in the left-hand side there get over to one of the outcomes? And I just listed the ones used by FDA, which are addiction, overdose, and death. How do they get from one side to the other? Well, the first, of course, is that the intact swallowing of pills is very common. And then it's a short jump there to go to chewing and swallowing your medication, which is quite common. And then you can go to crushing, and all of these increase the rate of your high and give you a, quote, better high. If you reach that stage, of course, you can go on to snorting and injecting as well. But the real point of the slide is to say that these groups are actually interrelated. The press and a lot of people actually tend to think you do one or the other, and that's really not true. You may snort and swallow crushed drug, for example, would be not uncommon at all, depending on I don't mean in one episode necessarily, but depending on what friends you're with and what environment you're in, you may use a different, and what drug you have available, you may use a different route. And all those really, though, can lead to one of the outcomes that we're concerned with, plus others. Now, this model gives us an idea of looking at how we can try to empty this balloon that has been filled over the past 30 years or so. Because really, when you look back, you can go back into really when I started training, it wasn't me really, but in the 80s, we started to see increases, and it was exacerbated certainly by the things that have been shown in previous presentations. But it's a 30-year process that people like me were taught that if you prescribed opioids correctly, a patient wouldn't become addicted. So that person in pain, now we can come up with something like a guidelines that we talked about, and certainly guidelines help you decrease inappropriate prescribing. In other words, how can I make sure I prescribe that drug for the right person, only the ones that need it? The PDMPs allow us to identify when a patient is developing risk behaviors that we really don't like, and we can hopefully intervene at that stage. Where can an ADF help, an abuse-deterrent formulation? Well, the first one is, I should say, that will decrease the transition to chewing, because if you do that, you will either have a very hard tablet or you'll get naltrexone. But also, it should intervene at any place where we have to manipulate the tablet in order to have abuse occur. And that, of course, leads to those outcomes. Now, this would decrease people entering the balloon. And there's other measures. I didn't put all measures on here, obviously. And then you need treatment to help empty the balloon, too, because there's already a lot of people inside the substance abuse balloon. Let's talk about temporality. We look at, this just means that the effect has to occur after the cause. With opioids, we expect a minimal delay, particularly for oxycodone ER, which I'm going to use as an example today. And that's because that an interesting experiment happened where all drugs shipped after August 9, 2010 went from an easy-to-abuse, crushable formulation to a more difficult-to-crush and solubilize version. Pharmacy turnover of opioids is rapid, so we don't expect a big lag in the effect that we would see. Unfortunately, this starts with a high abuse rate. Oxycodone ER obviously had a high abuse rate, especially per tablet dispensed, and so it gives us a high background to work from, which isn't true for all medications, but it's the best example that we have. So what would we expect if we had an effective abuse-deterrent formulation? First, we would expect prescriptions to go down. And you can see that's exactly what happened here. There was about a 15% reduction in oxycodone ER prescribing just in the first 3 months after its reformulation. And unfortunately, there was a potentially compensatory increase in prescribing of other opioids, which are defined at the bottom of the slide there. But they're basically all the tablet and capsule forms of opioids available on the market, all combined into one. Because we don't know what a person would switch to, but so we put those all in there to show that they actually went up while the oxycodone extended release was going down dramatically. Now I'm just going to go to an aside for a second to talk about radars. I promise it's only 30 seconds, but a lot of people don't understand what radars is, and we're the city and county hospital for Denver. So it's an independent post-marketing surveillance program, definitely nonprofit, focusing solely on prescription drug abuse. Most manufacturers of prescription opioids do subscribe to radars, and that's what supports its activities financially. So that's my conflict of interest statement. However, they're limited to use of that data only for regulatory or risk management purposes. We have all these programs I've listed at the bottom, and I'm going to show you our major ones in the next few slides to show you what we saw in terms of data. Most of these data will be corrected for population. We like the population denominator the best, we call it, because it's simply the number of events in a geographic area divided by the population of that area during the same time period. So that's pretty simple. The reason we like it is that it accounts for both of those parts of abuse I was mentioning earlier, which is that a reduction in obtaining the drug, in other words, people pursuing prescriptions less, and also a decrease in abuse after they get the prescription. For example, if we had the perfect ADF, as I mentioned earlier, I'd expect to see decreased doctor shopping. People would ask less for that drug and ask more for another drug. And that may seem crazy, but that happens quite commonly. So they can manipulate the prescriber to give them the drug they want. Also decreased pill mill activity, because if you're a dishonest prescriber, then you're going to prescribe the drug that your patients, so-called patients, want. But after you get that drug, then an abuse-deterrent formulation should decrease high-risk routes of abuse. So let's talk quickly about this data. I have tons of it, and I focused it down on just a couple slides. So looking at temporality again, this is data from our poison center system. So this is people calling into a poison center after they've had an acute event that involved intentional abuse. We're just looking at the intentional abuse category. We fitted this with a spline model with 2 knots. I don't understand all that, but maybe Tracy or somebody can explain it to me, but I have excellent statisticians that work with me. The reason is we saw these different phases, and we wanted to understand, visually saw these different phases, and we wanted to understand them. So you can see in that first phase, and I'm going to focus mostly on that, what we see here is the blue is other opioids, and that increases slightly, or is flat, is probably a better way of saying it, whereas oxycodone ER goes down. After that, they're not quite as different, and we're going to see that same phenomenon in other programs. So here's drug diversion. This is drug diversion investigators all across the U.S. opening cases and then recording what drugs were involved in those cases that they open. Again, from the time of reformulation there on the left, we see an increase in the other opioids and a decrease in oxycodone ER before the first knot. And then again, other opioids do go down. There is some trend there, but not during that initial phase. Opioid treatment programs, so these are methadone programs, and patients entering methadone fill out a methadone treatment program, fill out a questionnaire about all the drugs they have abused in the past 30 days. Here we can see that for the other opioids, it was decreasing slightly, and for oxycodone ER, it decreased dramatically during the first phase there, and then they become almost parallel after that. Very similar for what we call the survey of key informant patients. These are non-methadone treatment programs, so higher socioeconomic income for sure. It's very interesting that here we saw the other opioids actually increase about 20%, while oxycodone ER went down slightly in the first phase and more in the second phase. but actually parallel after that. Oops, forgot to do something. Well, anyways, the way we interpret that is that we have this 3 phases where we see divergent responses in the first phase, but pretty much concordant after that. And that suggests to us that we are seeing a difference that's specific to the abuse-deterrent formulation, in this case, in the early going, because there's not much else that could be a secular trend during that time. Another Hill criteria is effect size, and I'm going to use percent decrease. So this is the same data, but now expressed as percent change from the time of reformulation. So you'll see the same overall trends, but this is to give you an idea about the percent difference between them. For the poison center system, what we have is we see that, again, other opioids went up just a little bit, perhaps flat, whereas oxycodone ER went down 40%, just in the first year there. We look at drug diversion, very similar pattern, where it actually increases substantially. We're not sure why that peak is there, but even if we ignore that peak, it was stable, whereas oxycodone ER went down substantially, about 50% during that first period, and really today has gone down 90%. If you talk to drug diversion investigators, they just don't really see oxycodone ER on the streets anymore. Looking at opioid treatment programs, similar pattern. Marked decrease in oxycodone ER during the first phase. And then survey of key informant patients. Similarly, they stayed together for a couple quarters there and then separate, with oxycodone ER going down and becoming parallel after that. Okay, let's talk about consistency now, which simply says that findings observed by different persons in different places in different samples strengthens the likelihood of an effect. This is a compilation of data from a paper by Kaplan et al. And the lines in white are data I've already presented to you, essentially the same data source, so we're going to ignore those. I want you to see the ones in yellow, which are new data sources, just to show that there's consistency across multiple different data sources here. And whether we're talking about abuse in another treatment center program from Navapro, whether we're talking about opioid use disorder, overdose, or doctor shopping, we see very nice separation between oxycodone ER and other opioids since reformulation. We can look at still other databases like the NISTA, the National Survey of Drug Use and Health. This is the question specifically about endorsing non-medical use of OxyContin. You can see that peaked in 2010 and has subsequently decreased. We also have an interesting experiment that occurred, natural experiment, involving oxycodone ER and oxymorphone ER. The red line is oxycodone ER reformulation, and you can see that when it was reformulated, oxycodone ER went up dramatically, several-fold. This was quite stunning at the time. Then they introduced a reformulation, and you can see that there was an abrupt drop back to their baseline. So another issue is specificity. Now, I've already showed you data comparing oxycodone ER to other data systems. So I'm going to really here focus on a couple of concerns I have that were expressed by the FDA at ISPE last year. And that is, one comment was, for data streams that collect information, on a variety of events, changes should be limited to the abuse-related categories. And this is poison center data that I think is involved, and this shows different categories in the abuse, in the poison center data. And really, you can see abuse does go down quite a bit, as I showed you earlier, but also other categories go down as well. But actually, I think that this is not a correct statement, frankly. If I have a difficult to crush pill, difficult to chew pill, chewing a pill for pain relief is misuse, not abuse. And so we would expect that to go down. We also know that prescriptions go down, and so we would expect things like suicide and unintentional exposures to go down, because those events often involve drugs that is simply conveniently available in the house. When a person decides to do a suicidal gesture, they take what's in the medicine cabinet and ingest that. So I don't think this data is actually inconsistent with the abuse-deterrent features of oxycodone ER. Similarly, for evaluation of ADFs, changes should be seen only in the routes of abuse expected to be affected. And I agree with that statement, except it's how you interpret it. So for me, since a person often abuses by more than one route during a month, for example, then if they stop buying a product for oral or for snorting abuse, then we would see oral go down as well. This is a figure just showing alternate explanations, and I'm not going to go through this in detail except to show where the reformulation occurred and the relationship of the decrease in oxycodone ER, the red line, versus all these other events. And really, the best temporal relationship is certainly to the reformulation. I was asked to address a couple other issues very quickly. The effect of abuse-deterrent opioids on opioid-related harm in the community. This is a kind of a strange question because extended-release opioids have a very, very small part of the overall opioid market. We have a paper coming out on this, and really they account for the minority of abuse. People think they account for much more than they do. So in reality, we're expecting a small change in abuse from oxycodone ER to affect the entire abuse. It's not going to happen. You're never going to see it in such a large sample. How have abuse-deterrent formulations affected FDA policies and procedures and gaps in research? Well, the guidance is very good. I like it. It's been very useful. I guess the things I would suggest is that there needs to be some things defined, and I've listed them there to talk about more if people want to. Clarity there would definitely help. And more guidance about comparator drugs, because there's a lot of disagreements between sponsors and the FDA about what drugs are appropriate to compare to if you think your drug is abuse-deterrent. And finally, my favorite topic is the IR-ER issue, which I talked about on a previous slide, so I'll skip over that, except people need to understand abuse starts with immediate release preparations, not with extended release, typically. So in conclusion, the specificity, consistency, and effect size indicate to me anyways that the abuse-deterrent opioids are likely to be effective in reducing abuse and its outcomes. We have it not only for oxycodone ER, but evidence that's similar for oxymorphone ER, although I will admit that that interpretation is more nuanced and there's some strange data there. But imagine what would happen if we had widespread use. If everything was, if immediate release and extended release were abuse-deterrent, first we'd see prices come down. We're always worried about prices, but we could really, on a large scale, decrease this crucial transition from intact swallowing to crushing. But like other speakers have said, and I want to emphasize this, is that these are all tools. A PDMP, everything is a tool for only the educated, knowledgeable prescriber to use. If they don't know how to use them, then they can't use any of them correctly, and so that's actually the most important. Thank you.